Okay, shall we start?
Boleh, Prof.
Okay, ya. Okay, terima kasih Encik Buhari. Assalamualaikum, salam sejahtera. Thank you very much, all the attendees, ladies and gentlemen, to all the head of departments, professors, lecturers, our specialists, registrars, and of course our beloved medical student. It is our pleasure from our department, Otolaryngology and Neck Surgery, to organize this CPC this morning. Of course, we would like to also thank Encik Buhari and his technical support team for all their help. Before that, I would like to welcome all the presenters. Today is our CPC, Dr. Lam Sai Guan, or rather Mr. Lam Sai Guan, our young, eligible ORL head and neck surgeon. He's going to lead the CPC today. And of course, we have a good team of Dr. Irfan, who is our registrar. We have Prof Q, our good friends in ENT department. Dr. Q, Prof Q is consultant radiologist. And we have a medical officer from Pathology department, Dr. Roziasyazni, and Prof Nordashima will supervise her. So, you can ask questions in the chat box. The chat box or question and answer box, question Q&A box. And if you got time, we try to answer those questions. And there are a lot of possibilities when patient presented with head and neck mass. When a young or adult patient presented with head and neck, there's a lot of possibility. So you just have to know that not all neck lumps are MUMPS. So with that cue, I would like to pass to Mr. Lam to lead the CPC. All the best, Mr. Lam. Thank you.
And thank you, Professor Razif, for the kind introductions. So to start off the CPC today, we will be presenting a patient who presented with neck lumps. So first, I'd like to invite Dr. Irfan, who is our postgraduate master student, to present on the histories. Please, Dr. Irfan.
Good morning and Assalamualaikum. Thank you to Mr. Chairperson, Professor Razif, and Mr. Lam. So for our case presentation, Madam S, she's a 37-year-old Malay lady, no medical illness. She presented with a painless right neck swelling for 3 years duration. The swelling is increased in size, and she noticed that the swelling rapidly increased for the past 1 year. She has no obstructive symptoms such as dysphagia, shortness of breath. She has no dysphonia, muffled voice, or aspiration symptoms. She has no non-contact to TB patient, nor either have chronic cough or hemoptysis. She has no B symptoms such as night sweat, recurrent fever. She has no loss of appetite, loss of weight. She has no other symptom to suggest upper aerodigestive tract malignancy such as nasal obstruction, epistaxis, rhinophagia. For past history, she has no past or surgical history, no non-drug or food allergy, and she has no family history of malignancy. As for living, she works as a police officer and she's a non-smoker. For physical examinations, she's comfortable under room air. There's no sign of respiratory distress. There's no noisy breathing or stridor audible. Coming to the neck examinations, there's a right neck swelling at level 2 to 3, measuring 4 times 5 cm, and is firm in consistency and not tender on palpations. It has a smooth surface with normal overlying skin. And the lesion has limited mobility as it's situated below the sternocleidomastoid. And the swelling is not pulsatile and not fluctuant. So coming to the image, this is the anterior border of SCM, and this is the angle of mandible. The swelling located at the level 2 to 3. So we divide level 2 to 3 with at the level of hyoid bone. And it's different from the parotid swelling, as the parotid swelling usually situated higher up. Due to the mass situated deep to the SCM, it has a limited mobility. And on examination, it's not pulsatile, so it's unlikely it's from vascular origin, and it's not fluctuating. It's likely to be cystic in content. Going to intraoral examinations, there was no medialization of lateral pharyngeal wall at the oropharynx level, and Stenson duct is an opening of parotid gland. It's located at the buccal mucosa, opposite the second upper molar. So in this patient, it's normal. We did perform flexible nasolaryngoscope for this patient. This video shows a scope being introduced into the right nostril. This is at the area of posterior coena. This is the eustachian tube opening. This is the area of fossa of Rosenmuller, which is normal. Then going down to oropharynx level, it's normal. Let me orientate you guys. Okay, this is the anterior part. This is posterior part. This is right side and this is left side. This is epiglottis, left arytenoid, right arytenoid. This is the right false chord and right. The lower down is the right true chord. This is the left false chord and left true chord. Then we can see that the left piriform sinus is not obliterated. However, on the right side, it's obliterated by the medialization of the lateral pharyngeal wall at the level of hypopharynx. We can see that the vocal cord is mobile. It's adducted during phonation. Okay. Based on the history and physical examination, we are thinking that the swelling is arising from the parapharyngeal space. So due to that, it can cause it will likely arise from parapharyngeal space. So it can involve the lower cranial nerve, especially the 4 lower cranial nerve. So in this patient, the glossopharyngeal nerve is normal. It has no curtain sign. For vagus nerve, the gag reflex is intact. There's no dysphonia. For spinal accessory nerve, she has no shoulder weakness. And for hypoglossal nerve, it has no deviation, tongue deviation of respiration seen. This video shows how we perform a voice assessment in our clinic. We are using a standardized script for patient to read and record the video. We score the voice using RABA scoring, which score 1, 2, 3 depend on the severity. It has 4 components of dysphonia that are being assessed. There is roughness, breathiness, asthenia, and strain.
Saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, emak, abang dan adik datang menziarahi kami di kampung. Saya gembira apabila mereka datang kerana saya boleh bermain bersama-sama abang dan adik.
Okay, coming to the diagnosis, our provisional diagnosis is right parapharyngeal tumor. It can be neurogenic origin or it can be from salivary gland tumor. If a neurogenic origin, schwannoma is the most common. And if a salivary gland tumor, it can be due arising from minor salivary gland tumor at the parapharyngeal space, or it can be arising from the deep lobe of parotid. As for differential diagnosis, it could be cervical metastatic tumor from head and neck malignancy, but it points against this, the swelling has been there for 3 years. However, it can be due to occult primary also. And the second is a TB lymphadenitis caused by the chronic glomerulus inflammations. However, point against is that she has no TB symptoms or contact, and usually TB lymph node have caseous center and less firm, and will eventually have past discharge. And the third differential will be lymphoma. Blood investigation for this patient, we took a full blood count, and the result was were normal. There's no suggestive of any ongoing infections. And the renal profile is normal. And as for radiological investigation, the chest X-ray is normal. There's no feature suggestive of TB infections or any lung infections. The other radiological infections will be investigation will be presented by Prof Q after this. Thank you.
Okay, thank you, Dr. Irfan, for the presentation. So in summary, you can say it's a young lady presented with a 3-year history of a right lateral neck mass. And she's otherwise asymptomatic, right? She has no compressive symptoms. Cranial nerve examinations are all intact. And the examination is a single a single mass at the right lateral neck, deep to the sternocleidomastoid and deep to the mandible, most likely in parapharyngeal space. And a question to Dr. Irfan: if, let's say, you would like to investigate this patient, you choose FNFC, or at this point, would you proceed with imaging first?
I would like to proceed with imaging because we cannot rule out a vascular tumor from parapharyngeal space. Even though it's not versatile, but it's better to have a radiological imaging before we proceed with histopathological examinations.
Yeah, correct. Because it's indeed in parapharyngeal space, one of differential paraganglioma or vascularized tumor. So I think it would be safer if we perform radiological imaging first. So for that, I would like to invite Associate Professor Q to present on this patient's imaging. Please welcome Prof. Q.
Okay, let me try and share the screen. Okay, can you see my screen?
Yep.
Okay, yes. Great. Okay, good morning. I'd like to thank the Otorinolaringologi department for inviting me to be part of this eminent CPC meeting. So this morning, my remit is to discuss and present to you the imaging findings for this patient. So we have here a CT examination with contrast for this patient. So for the medical students, you can see that on the left-hand side, we have an axial view of this patient. And then on the right-hand side, we have a coronal reconstructed image for the same patient, the same setting. We know that it's contrasted because the vessels are lighting up with contrast. So this is the ICA, and that's the IGV on the normal side. You can see that the lesion is shown here by the yellow asterisk on the axial view here. And also on the coronal view here, you can see that, in fact, it is quite ovoid in shape. It's got, this very, oval shape to it, but otherwise well encapsulated, and it extends somewhat to the level of C1, and then goes down to just about the laryngeal inlet. So level of that. So and we look at the contrast enhancement of the lesion. It's actually quite poorly enhancing. We just see some, very, very minimal areas of enhancement within the lesion itself. Now, if I can draw your attention also to the fact that there is a little bit of medialization of the pharynx, as was seen at the scope. The red arrow points to the ICA. Now, if you compare the ICA on the right side to the left side, you can see that it is quite markedly anteriorly displaced. The IGV itself is not displaced so much anterior or posteriorly, but it's kind of laterally displaced somewhat, a little bit posterior laterally displaced. So you can see, in fact, that there is some separation of the ICA from the IJV on the right side. Okay, and then of course there's some mass effect on the right submandibular gland as well, which you can see the counterpart here. It's actually a little bit pushed anteriorly by mass effect as well. Otherwise, there's no fat stranding around this lesion. There's also some mass effect on the sternocleidomastoid muscle on the right side. This is the left side to compare. Okay, so now if I ask you to just focus on the ICA here, pointed out by the yellow arrow on this image on the left hand side, if you just follow that image as I play this video. Oh, sorry. Okay. Again, the ICA on the right side, I will play the video. Okay, you can see that it's somewhat anterolaterally displaced. There's ECA coming in, this CCA. Yeah, okay, maybe a little bit too fast, but I hope you can see at least that the ICA was anterolaterally displaced by this lesion. Okay, so how would the thinking go in terms of the radiological diagnosis? So we have here a right parapharyngeal lesion. It looks fairly benign, just looking at the well-encapsulated nature of it, and there's no infiltrative or kind of aggressive features that we can see. It has anterior displacement of the ICA, as I've discussed. Now that puts it squarely in the post-styloid compartment of the parapharyngeal space, and we'll go through later what that means. Now, if we think about compartments and differentials, the commonest lesion in this compartment would actually be a neurogenic tumor. So that would include things like schwannomas and also a neurofibroma. Okay, the next thing we think about is what kind of enhancement pattern we're seeing. Now, if you look at the enhancement, it was quite poor, as I mentioned. So that, in fact, is quite consistent with a schwannoma. Schwannoma is also a lot more common than a neurofibroma. So in this case, we can effectively exclude paraganglioma because those would be much more avidly and intensely enhancing. So there's no evidence on the CT that we're dealing with a paraganglioma. And because of all the features, of this CT, the diagnosis most likely is that we're dealing with a right-sided vagal schwannoma. A possible differential is that instead of coming from the vagus nerve, in fact, the schwannoma may actually be coming from the right sympathetic chain. So there are certain criteria to decide whether it's vagus or sympathetic chain, but I think it may be beyond the scope of this CPC. But for now, yeah, I think we consider a vagal schwannoma and differential sympathetic chain. So to just quickly go through the pre-styloid parapharyngeal space, it contains fat minus glands, branches of the mandibular branch of trigeminal nerve and some vessels. So this is the pre-styloid part of the parapharyngeal space. A commonest lesion here is actually a pleomorphic adenoma, either from minor glands or the deep lobe of the parotid. And typically what you see is, again, a very well encapsulated lesion, displacing the parapharyngeal fat. The key sign here is that the ICA will be displaced posteriorly. So the blue arrow points to the ICA and it is displaced posteriorly. So that's converse to what we are seeing in our case. When you see that, that puts it in the pre-styloid parapharyngeal space. And so the most likely lesion in this location and these features would be a pleomorphic adenoma from the minus glands. Now, if you happen to see this sign, so again, we have a lesion now on the left side. Again, very, very similar. It's got parapharyngeal space effacement. It looks very well encapsulated. But if you look at the yellow arrows here, stylomandibular tunnel, which is the distance between the styloid process and the ramus of the mandible, is in fact widened on the side of the pathology. Now, if you ever see that sign, it's a very good sign to indicate that, in fact, the lesion may actually be coming from the deep lobe of the parotid gland. And in fact, we do see some degree of enhancement in the parotid space on the left side. And an MR, also shows you kind of the same findings of the widening of the stylomandibular tunnel. If you see this sign, it's a very helpful sign because it tells you that the pleomorphic adenoma, in fact, comes from the deep lobe of the parotid gland. Now, we go now to the post-styloid parapharyngeal space, which is what we're dealing with today. Now that, in fact, contains the carotid sheath. So, you have the ICA, IJV, you also have cranial nerves 9 to 12, glomus bodies, and also the sympathetic chain. So the main lesions here would be neurogenic tumors. Also, you can also get vascular things like paragangliomas. So again, to emphasize again, what we will see in the post-styloid parapharyngeal space lesion is the ICA displaced anteriorly, as shown by the blue arrow. So this is another case, not of this patient, whereby it was a vagal schwannoma. You can see the very typical anterior displacement of the ICA on the same side. Again, very capsulated lesion, not much enhancement, very clean planes with surrounding structures. So if we look at a summary, so if you have ICA displaced anteriorly, we're dealing with a post-styloid parapharyngeal space lesion. If the ICA is displaced posteriorly, we're dealing with a pre-styloid parapharyngeal space lesion. And in both cases, the most likely lesion in the post-styloid parapharyngeal space is a vagal schwannoma. The most common lesion in the pre-styloid parapharyngeal space is a pleomorphic adenoma. Now, of course, as discussed before, you can also sometimes get vascular lesions such as paragangliomas. So this is an example of a carotid body paraganglioma. It is a lesion that sits literally in the crux of the carotid bifurcation. And it tends to splay the ICA ECA in this very typical Lyre sign kind of pattern. You can see the same thing as well on this angiographic image, which has been subtracted. Now, the classic sign, of course, is that at MRI, one sees flow voids within this lesion. They tend to enhance very, very avidly. But the classic thing we must look for is the flow voids. So usually, I would say MRI is better for looking at these flow voids. Which is not the case. We don't see any evidence of a paraganglioma for our case. So in summary, as a take-home message, CT or MR allows for the most part, accurate diagnosis or appropriate differential diagnosis of parapharyngeal lesions in most cases. The main thing to take away is location, is to define clearly where is the actual location of the lesion, because that narrows down the differential effectively in most cases. At the post-styloid parapharyngeal space, one also wants to pay attention to the vascular splay pattern, lesion vascularity, and to look for any findings that may suggest a vascular like paraganglioma in some cases. So yeah, with that, I'd like to thank you.
Thank you, Dr. Prof. Q, for the great presentation. I think it showed us quite clearly that how important is imaging in helping us to come to the diagnosis in a patient with parapharyngeal tumor. So I would say in this patient, the tumor in imaging is well circumscribed and looks like a benign tumor, and it's mainly situated at post-styloid compartment, and it's not really highly vascularized tumor. So combining all these features, I think the likely diagnosis is neurogenic tumor. So I'll proceed with the intraoperative finding. So this patient had underwent excision of the tumor. The surgery was performed by Professor Mohamad Razif and assisted by Prof. Marina and myself. So again, we look back at the photo of this patient. She had a mass at the right lateral neck, deep to the sternocleidomastoid and to the ramus and angular mandible. So we approach the tumor via transcervical incisions. Usually the incision we do, we design is about 2 finger breadth below the angle of mandible to avoid injury to marginal mandibular nerve. So in the picture on the right, that shows that after we did the incision, we raised the subplatysma flap. So here you can see the seal hood of the external jugular vein and the great auricular nerve. So subsequently, when you raise the flap, inferior and posterior flap, we identify the sternocleidomastoid muscles. Then we retract the muscle posteriorly. So we can see more clearer the external jugular vein and the internal carotid artery here. And posterolaterally is the internal jugular vein, and you can see the tumor deep to these vessels. And crossing transversely the carotid arteries is the hypoglossal nerve. So this video shows you that you can see the carotid artery here and it's pulsating. So we further retract the great vessels away from the tumors. So you can see more clearer the tumors here located deep in the parapharyngeal space. And we can see that the features were consistent with the imaging, that it displays the internal carotid artery anteromedially, and it displays the internal jugular vein posterolaterally. It was hidden deep to the sternocleidomastoid. And the hypoglossal nerve was seen traversing the carotid arteries. Yeah, then we retract further, we can see the tumor more clearly. So this video showed that after we dissect the tumor, mainly with blunt dissection, we dissect out the tumor using a harmonic scalpel. And this is the final picture of the tumor, with the greatest dimension measure about 6 centimeters. And this video showing that after the tumor was dissected out by Prof. Razif, we can see that, this is a tumor. Measure about 3 by 6 centimeters in diameter. Then we can see that this is we are showing that this is the internal carotid arteries, and this is the internal jugular vein. This internal carotid artery, and traversing the carotid arteries are hypoglossal nerve. And deep to internal carotid and internal jugular vein, sitting in between them posteriorly, is the vagus nerve. You can see the vagus nerve is intact in this case. Okay. Subsequently, post-operation, the patient was noted to have a partial ptosis of right upper eyelid and meiosis. But there was no anhidrosis and ophthalmos. So we postulate that most likely the tumor may be arise from the sympathetic, cervical sympathetic trunk. The patient has no hoarseness, the vocal fold remains mobile, means that the vagus nerve function remains intact. No deviation of tongue, means that hypoglossal nerve was intact. Shoulder weakness was there was no shoulder weakness, meaning that the spinal accessory nerve was intact. But the weakness of the eyelid and the meiosis was transient and subsequently resolved 3 months after the surgery. So now I'd like to pass to Dr. Roziasyazni from the Department of Pathology to present on the histopathological examination of the tumor.
Okay, thank you, Mr. Lam. Okay, Assalamualaikum and good morning, everyone. I am Dr. Roziasyazni from Pathology Department. So I will present the histopathological examination for this case. So we receive two specimens, label as A, right parapharyngeal mass, and B, right level 2 lymph node. So this is specimen A, right parapharyngeal mass. We receive a well circumscribed mass measuring about 5.2 centimeter in largest diameter. On cut section, this mass shows well circumscribed and encapsulated mass with 10 grayish solid cut surface and multiple areas of hemorrhage, like this area and this area. However, there is no necrosis seen. Several sections were sampled for microscopic examination. So this picture is a low power view of the tumor, and it shows a well circumscribed and encapsulated tumor and surrounded by this thin fibrous capsule. From this low power view, you can appreciate this tumor is composed of hypercellular Anthony A area, more towards on the right side, and hypocellular area Anthony B, more on the left side, and also presence of scattered dilated blood vessels. So this is a high magnification of the hypercellular area, Anthony A. It's composed of spindle-shaped neoplastic cells displaying elongated tapered end nuclei, or hyperchromatic nuclei with inconspicuous nuclei and indistinct eosinophilic cytoplasm. So in other areas, the neoplastic spindle cells show nuclear palisading, forming Wernicke body, sample like this area. This picture is a high magnification of the hypocellular Anthony B area that demonstrate loose edematous and myxoid stroma with less spindle neoplastic cell. So again, this picture show capsulated mass with hypercellular area and also hypocellular area with scattered blood vessels, dilated blood vessels, and some of the blood vessels show hellenized vessel wall, like these vessels, and also these vessels. And also we can see areas of hemorrhage here. However, there is no necrosis seen. So we proceed with immunohistochemistry study. So these spindle neoplastic cells are strongly and diffusely positive for S100. So based on clinical findings, radiological findings, and typical morphological features on microscopic examination, we conclude that the right parapharyngeal mass is a schwannoma. So for the B, specimen B, right level 2 lymph node show normal lymph node, normal histology of the lymph node. This is a lymph node surrounded by thin fibrous capsule with normal lymph node architecture. And this lymph node composed of lymphoid follicles, okay, and also sinus histiocyte. Yeah. And some of the lymphoid follicles shows prominent germinal center, like this one. And there is no evidence of malignancy. So we conclude that the right level 2 lymph node is just a active normal lymph node, negative for malignancy. So I think that's all from me. Thank you.
Right. Thank you, Dr. Yazni. I think the HPE findings were quite consistent with neurogenic tumor, especially a schwannoma, with a cluster of Anthony A cells and Anthony B cells, and especially the immunohistochemical stain showed that S100 is positive. So I'll proceed with the my presentation. So a parapharyngeal space and in generally is an anatomical relatively complex region. So the treatment of parapharyngeal space tumor is quite challenging due to the proximity of the tumor to the vital neurovascular structures. So as explained by Prof Q just now, you can see that a lot of major vessels are contained inside the parapharyngeal space. For example, the carotid arteries, the internal jugular vein, the lower forecranial nerve, and other nerves such as the ansa cervicalis, the cervical sympathetic trunks. And also it contains some lymph nodes, the fat muscle, and also the deep lobe of the parotid gland. So for students, this picture is very important. So you can see that this is a diagram showing the parapharyngeal space. You can see parapharyngeal space is an inverted pyramidal in shape, with the base at the skull base, and the tip of the space is at the greater corneal of hyoid bone. So medially, it was bounded by the pharyngeal constrictor muscle and also buccopharyngeal fascia. That's why if a tumor here, if there is a mass effect, so there you see bulging inside the pharynx, the oropharynx or hypopharynx. Laterally, it was bounded by the parotid glands. So you see the part of parotid gland, deep lobe of parotid gland extend into the parapharyngeal space. If you see this axial view, you can see the carotid sheath located inside the parapharyngeal space, mainly the post-styloid compartment. And it contains the internal jugular vein, the carotid arteries, and the vagus nerve. So I think, I think Prof Q explained how we divide a pre-styloid and post-styloid compartment. So you can see that these ligaments, or mainly we call it tensor vascular fascia plane, which divide the pre-styloid and post-styloid compartment. In pre-styloid compartment, it mainly contain the deep lobe of parotid glands and some fat and probably some lymph nodes. And the major neurovascular structure are mainly located in post-styloid compartment. But there was just a diagram to show, to simplify the structure. In real life or in real patients, these structures are located very near to each other. So you can see this is an anatomical picture showing that the sternocranial muscle was removed and the internal jugular vein has been cut. You can see here the internal carotid arteries, and lying on top of the carotid artery, here is the hypoglossal nerve. Here is the ansa cervicalis, and between the carotid artery and the internal jugular vein is the vagus nerve. So again, this is showing the common carotid, which branch into the internal and external carotid arteries. And this is a posterior belly of digastric, which is very important, especially to ENT surgeon. We call it the residence friends because it gives us a landmark on all these important structures. Anything deep to it, we must be careful when you approach anything deep to the posterior belly and digastric. Because you can see here is the internal jugular vein, here's the carotid artery, and all the lower forecranial nerve. So we can see in between the internal jugular vein and the carotid artery lies the vagus nerve. So again, this shows the carotid content of the carotid sheath, which contain the internal jugular vein and carotid artery and the vagus nerve posteriorly. And outside the carotid sheath, posteriorly, there lies the cervical sympathetic trunk. And anteriorly and superficial to the carotid sheath are the ansa cervicalis nerve. So again, this is the tensor vascular styloid fascia, which divide the pre-styloid and post-styloid compartment. And you can see pre-styloid mainly contain the deep lobe of parotid and fat and lymph nodes. And the big vessels, the carotid, internal jugular vein, the cervical sympathetic chain, the vagus nerve, and some lymph nodes are mainly at the post-styloid compartment. So understanding this anatomy is very important to understand the origin of the tumor and the pattern of displacements of these great vessels. So primary parapharyngeal space tumors are rare, account for only 0.5% of all head and neck tumors. And 80% of all these primary tumors are benign, only 20% are malignant. So the commonest benign tumor in the parapharyngeal space are salivary gland neoplasms, and most of it are benign, arising from the either deep lobe or minor salivary gland, and small percentage are malignant salivary gland, mainly mucoepidermoid, acinic cell adenocystic carcinoma. And it was followed by neurogenic tumor, and more commonly schwannoma, and less commonly paraganglioma, which are a vascularized tumor, arise from neuroendocrine cells, for example, carotid body tumors or glomus tumors. There could be some other possibilities in the parapharyngeal space, such as lymphatic malformation, hemangiomas, or some other vascular tumor. Or those tumors arise from fat lipoma, lymphoma, sarcomas, or it could be metastatic lymph nodes from the upper aerodigestive tract, such as nasopharynx, oral cavity, oropharynx, or also thyroid gland. Here you can see there's a long list of differential diagnosis of primary parapharyngeal tumor, but mainly it was a benign salivary gland tumor from deep lobe or minor salivary gland, and also the neurogenic tumor and paraganglioma. So the symptoms and signs of parapharyngeal space tumors are subtle, as is seen in this patient. She just had a neck lump, and other than that, quite asymptomatic. And small tumors usually are relatively asymptomatic until it grows larger and cause patient notice there's a neck mass, or the mass has a protrude into the oropharynx that patient feel there's a lump in the throat. And that's why it was usually diagnosed only when they become large enough, usually about 2.5 to 3 centimeters, to be detected, to be palpable or detected in the neck or oropharynx. Large tumor that expand medially may cause obstructive symptoms into the pharynx. If the tumor at the level of oropharynx, patient feel a lump in the throat, patient may feel a bit of dyspnea, or it can cause a disturbance in the swallowing, causing dysphagia, or patient may present with sleep apnea symptoms. If the tumor is higher up in the nasopharynx level, it may compress on the eustachian tube and cause patient having oral fullness, tinnitus, and hearing loss, especially conductive type. If the tumors are the paraganglioma and is secreting catecholamines, patient may present with symptoms such as headache, labile hypertension, palpitation, flushing, and sweating. And if patient have lateral neck mass and present with cranial nerve deficit, first we have to think of malignant tumor. Because in benign tumor, even though it's neurogenic in origin, patient not commonly or quite rarely they present with cranial nerve deficit. And what are the things that we like to see during physical examinations? When you palpate the neck mass, we have to differentiate it whether it's a parotid in origin or it's coming from parapharyngeal space. So neck mass, and those arise from parapharyngeal space, is usually deep to sternocleidomastoid muscles and also deep to the ramus and mandible. So if you also palpate the parotid region near the angle of mandible, see whether there's any parotid swelling. Then we check the oropharynx. We can see that there is if the mass has protrude into the oropharynx, we can see that there's a submucosal mass that displays the lateral oropharyngeal wall, the tonsil, and soft palate anteromedially. And in our ENT practice, we will perform indirect laryngoscopy to assess the medialization of lateral pharyngeal wall, and so to see the vocal fold mobility, whether the mass has caused vagus nerve palsy. And you should perform a complete cranial nerve examination, especially the lower four, see any cranial palsy. Check the Horner syndrome, and if the tumor is arising from the cervical sympathetic trunk. If patient has trismus or the mass is painful with cranial nerve palsy, it often suggests a malignant tumor. So if patient is parapharyngeal tumor, how do we investigate? Imaging studies plays a central role in diagnosis and pre-op planning because it provides information on the size and the precise location and the origin and also relationship with the surrounding structures. And this differentiation is critical in differential diagnosis and give us information, especially the surgeon, on the potential surgical approach to the tumor. So the imaging usually performs either CT scan, contrast, or MRI. And the CT scan, if the tumor is well circumscribed, most likely it's a benign tumor. If it's a malignant tumor, the margin is not well defined. And if there's any erosion of bony structures, such as mandible, skull base, it suggests of a malignant tumor. You can see the tumor, there is a preserved fat plane with a parotid gland, then most likely it is not a salivary gland in origin. And if a neurologic tumor usually appear quite homogeneous, and the vascular tumors such as paraganglioma will enhance brightly on the contrast administration. MRI offer better soft tissue delineation, and it can differentiate paraganglioma by presence of a signal flow void because of high vascularization, and it appears as a salt and characteristic salt and pepper appearance. So these are examples and what we want to see when we are looking at the imaging or the CT scan or MRI. First, by the patterns of the mass displays the parapharyngeal fat. So it gives us a clue that where's the origin of the lesion. So this is a normal CT contrast scan. You see the asterisk showing the location of parapharyngeal fat. This is the deep lobe what we did in this patient. There are many other approaches, depends on the location of the tumor, the size, and the relation of its vascular structures. For example, transparotid, transmandibular, transoral. And we can combine this approach also, such as a transcervical transparotid or transcervical transmandibular approach. It depends on the location of the tumor. One of the important considerations is whether the surgeon can have a good vascular control and exposure to the cranial nerve. Depends on the approach. So briefly on transcervical approach, usually we do a transcervical horizontal incision at the neck, about 1 to 2 finger breadth below the angle of mandible. Then we raise the subplatysmal flap. We identify the marginal mandibular nerve and preserve it. Then we identify the sternocleidomastoid muscle and we check it posteriorly to expose the great vessels, the tumor. And it can the approach can be extended if we can divide the posterior belly of a digastric or stylohyoid or styloglossus muscle or even styloid process to increase the access to parapharyngeal space and increase the view, the surgical view to the parapharyngeal space. And then we identify the vital structures and tumors dissected free. And if it's a neurogenic tumor, vacuousness identified by the intraoperative nerve monitoring, then we can dissect superiorly, creating a plane from the carotid artery. Then after the tumor is out, careful hemostasis is secured and put in a drain. If the tumor is from the deep lobe of parotid or deep to the parotid gland, then transparotid approach is preferred. Then we use a modified Blair incision, then we may extend the preauricular limb higher up. Then we do superficial parotidectomy. We remove the superficial node of parotid. Then we identify the facial nerve from the trunk and all the peripheral, all the terminal branches. Then, of course, in this surgery, we use facial nerve monitor. And then we lift up the facial nerve to approach, go into the parapharyngeal space and dissect the tumor out from parapharyngeal space, preserving the facial nerve. Transmandibular approach involving split and the mandibulotomy. Depends on the location, can do median, paramedian, or even lateral osteotomy. Then we dissect the tumor out to the constrictor and thoracic muscle to expose the tumor. Then tumor is excised and also at the same time preserve the vital structures. And after the surgery, we need to fix the mandibulotomy using mini plates. The advantage is it offers good exposure and good vascular control, but the disadvantage is that we may injure the inferior alveolar nerve when doing this mandibulotomy, and the subsequently patient may have risk of malocclusion or non-union. And because of the scar is bigger, it offers less cosmetic outcome. Transoral approach is only reserved for small tumor and with a benign, usually benign, well-encapsulated tumor and avascular. And those tumors that projecting into the oral pharynx and really near to the oral pharyngeal mucosa. The disadvantage is the view is very limited and the space is very small, and that's why there's risk of increased tumor spillage and also injury to the vessels. So this is just a guideline on how we approach, how we choose the approach to the parapharyngeal space. If after the imaging, we can conclude where's the origin of the mass, whether it's pre-styloid, post-styloid, whether the tumor is vascularized, whether angiogram is indicated. If the tumor is quite high up and near the skull base, then transmandibular approach is preferred. Or if the epicenter tumor is near the neck and not exceeding the superiorly to the styloid process, then the transcervical approach is preferred. If the tumor is deep to the parotid gland, then transparotid gland is transparotid approach is preferred. And this is a case that we did previously also with Prof. Razif and Prof. Marina, and patient have bilateral neck swelling, and it was neurogenic in origin, but it's not the sonoma, but it's a neurofibroma, because this patient has a neurofibromatosis type 1. You can see a big cafe au lait spots on the skin. And similarly, we see that this mass is located deep to the great vessels, and you see the mass is actually attached to the hypoglossal. This is a hypoglossal nerve. The mass is attached and arises from the hypoglossal nerve. So as a result, after we dissect the tumor, we can expect the patient have hypoglossal nerve palsy. So for nerve shift tumor, surgery remains the mainstay of the treatment. Some surgeons may attempt gross tumor resection with preservation of neural function, and some advocate intracapsular enucleation so that they hope that they will preserve the nerve function. But this patient, post-operatively, nerve palsy still occur in about 16 to 40%. And because they preserve some of the tumor capsule, some of the residual tumor may present in the capsule and leading to recurrence. The potential complication, as explained earlier, because of the close proximity with the vital structure, it may cause this injury to the vagus nerve, leading to vocal fold palsy. Patient has aspiration, and facial palsy commonly in transparative approach because we may injure the facial nerve, but it's usually temporarily due to traction and may recover in 3 to 6 months' time. And if patient has cervical sympathetic trunk injury, patient develop Horner syndrome. And if glossopharyngeal injury, patient develop velopharyngeal incompetence and nasal regurgitation. Patient have 11 and trap palsy. Patient have shoulder weakness, tongue weakness, dysarthria and dysphagia. Vascular injury causing a severe hemorrhage experienced from the artery, and Frey syndrome because of the aberrant re-innervation of the parasympathetic nerve that supply the parotid gland to the sweat glands. First bite syndrome because of this parasympathetic overactivity when patient having a severe pain when they bite the foot. And other complications such as hematoma, seroma, and tumor recurrence. So in our center, if we know that the tumor is a neurogenic in origin and patient will have a nerve dysfunction, especially vagus nerve, after resection, we do primary non-selective laryngeal re-innervation by our laryngologist, Prof. Marina. So immediately after the resection of tumor, if the vagus nerve deficit is detected, we can do a non-selective laryngeal re-innervation either by free nerve grafting, or we take the ansa cervicalis to the recurrent laryngeal nerve. The aim is to restore the innervation and preserve the tone and bulk of our vocal fold. And at the same time, we can do concurrent injection laryngoplasty and to the vocal fold while waiting the effect of the re-innervation to take place. So in summary, surgical management of parapharyngeal space tumors is challenging because of the wide spectrum of the benign and malignant tumors, because of its deep location, and the complex anatomic relationship with nearby neurovascular structures. So majority of the parapharyngeal tumor are benign, and the radiological studies are essential to help us on the diagnosis and surgical planning. And the surgeon must have a firm knowledge of anatomy, a strategy of preoperative evaluation, and a different surgical approach to parapharyngeal space are essential to minimize the patient morbidity from surgical resection of the tumor. And the treating nerve dysfunction by primary intervention also will minimize the post-op morbidity. So with that, I thank you. I will pass back the floor to the moderator, Professor Razif.
Okay, thank you very much, Mr. Lam. Indeed, it's a very comprehensive and very nice presentation. Definitely a question for postgraduate. So all the question is actually inside there, Lam. So we have a question actually by Prof. Dekan. So again, thank you very much, Prof. Dekan, who attending this CPC. I already answered in the live chat. and also he has to excuse himself for another meeting. So it's already like 9:05. I think we need to stop here. Just quickly wrap up about the CPC today. This is a complex area. Parapharyngeal is a complex area. So this is where we challenge ourselves in terms of managing the case from clinical findings to radiological and to the histology. So because in clinical findings just now, why we take it of parapharyngeal? Because there is a medialization of the lateral pharyngeal wall. So for all audience here, if you have a neck mass, doesn't mean it's parapharyngeal. But if you see intraoral examination, there is a medialization. And if of course, if there is a lower cranial nerve involvement, definitely we're thinking of parapharyngeal mass, the location, the parapharyngeal area. As mentioned by Prof Q, CT scan or MRI is the gold standard for us to know exactly where is the tumor arising from, either pre-styloid or post-styloid. And we can guess exactly what it is. And after we remove with approach mentioned by Mr. Lam, Guan just now, I must tell you, when we want to resect a tumor in parapharyngeal space, as you can see, is a lot of lower cranial nerve and also major vessels. So looks cool, but God knows the heart rate that we have while operating the case. So the approach is one thing. And then after that, of course, we give to Dr. Roziasyazni and the team to tell us what exactly it is. And my last sentence is, we plan, okay, but unfortunately, fortunately to the patient, but it's anticlimax to us in the sense that we thought this is from vagus nerve, so we can do a lot of other things to repair the nerve, but it turned out to be from peripheral nerve. So good for the patient, but of course our registrar and specialist disappointed because they want to see the nerve repair at the same time. So then again, when we treat the patient, end of the day is we wish the best for the patient and not for the doctor's benefit. Okay, so with that, any other things? The Kahoot thing, what is it? Kita ada Kahoot quiz and CPD point QR code. Okay, thank you Encik Buhari. So I think Lam, we can end, right? All right, so ladies and gentlemen, Dr. Irfan, Mr. Lam, Prof Q, Dr. Roziasyazni, Encik Buhari and the team, Dr. Azmi, Prof Azmi Tamil, always man behind the scenes. So thank you very much, and all the attendees. We hope that we learn from each other, and again, teamwork is important. Okay, ladies and gentlemen, thank you very much. Have a good morning. Thank you. Now we are done, right?
Ya, Prof. Boleh leave.
Okay.
Kita ada Kahoot quiz Okay, terima kasih Prof.
Thank you, Prof.
untuk medical students, sila gunakan nombor metrik. Terima kasih.
Okay, thank you everyone. Thank you, Encik Kari. Okay, bye-bye.
Sama-sama.